Mr. Imran asked me to do a presentation, I was thinking what would be the best way to engulf an interest of both cardiologists and cardiac surgeons. And I thought of discussing what I consider an unusual cause of chest pain that we do encounter very rarely in our practice, but it does actually exhibit lots of questions as what is the best way to manage these patients. Sorry, this is the wrong one. Sorry, they got the wrong presentation.
Sorry for inconvenience. Sorry for this disturbance. Even due to this reason, this issue, we have changed the venue. We're supposed to have a meridian, but here we found the same issue with this technical. So I apologize for this. Sorry, Dr.
That's okay.
No worries. There are
Right, I'll try to go fast. Now, it was one late evening in one of the clinics, and it was a 37-year-old male with few weeks history of malaise and fatigue, but no other symptoms. Actually, he was quite healthy. He attended few general medicine clinics, with normal bloods. So I knew he had normal biochemistry and hematology and all over. His wife, cleverly enough, noted that he gets lower left side chest pain during long distance driving, but that was all. There's no relevant past history. So it's one of the cases that does not really attract you during the clinic. Bedside examination, as you may expect, was absolutely normal. So was his ECG. Again, his biochemistry and hematology from our records was absolutely normal. So it was really all clear. So I thought, what would be the next thing to do? It looks like an atypical chest pain. And here, I just want to raise a flag for a chest X-ray, as over the years, it remained one of the most powerful, underused tools for diagnosis in cardiology and medicine at large. So I sent him for chest X-ray, and that was a chest X-ray. And I don't think you will get lots of marks by noticing that he got a mass, a well-defined mass on his left side, just exactly as was described by his wife, where he's getting chest pain, rubbing against the belt of the car for long distance driving. But as you can probably see, the delineation of the cavity of the left ventricle is well away from this mass. But he had chest pain, and he came to seek help from this chest pain. I hope it works. Okay, so the echocardiogram, he had normal cavity size. I can assure you that whatever that thing is, it was not leaking into the left ventricle, not on the right ventricle. All his chambers were normal. And this was a full assessment. I'll have to point it out because they were supposed to play, but it's not playing anyway. So this is what I was seeing on a chest X-ray, right exactly on the top head of the left ventricle, seen on the two-chamber view, the four-chamber view, two-chamber view, three-chamber view, and the four-chamber view. So there is a big hollow ahead of the left ventricle. And on the tissue deformation imaging, it was actually affecting the contractility on the apical segments. So whatever that mass is, although his low global longitudinal strain was normal, but this mass was significantly exerting disturbance of the function on his left ventricle. So this is actually supposed to be a moving image, but I'm not going to endure you through another process of checking the techniques of whether to get it right. Anyway, this is the left ventricle, and this is the mass which we are getting. It's in complete isolation of the left ventricle, and it has its boundaries, but I cannot obviously by echo get to the end of it. So my echocardiogram with a cystic mass, but obviously it is a cyst. It's attached to the lateral wall of the left ventricle with no communication to the left ventricular cavity or any way of the other cardiac chambers. It is not isolated from the pericardium, and you could have seen that clearly when the videos were playing, when the heart itself was structurally normal. My working diagnosis was possibly a pericardial cyst based on the echo and the chest X-ray. So the chest X-ray, the former report was a left side well-defined opacity, quiricardiogenic, quiribronchogenic cyst, and quiridiaphragmatic hump. So what would be the next way forward? What would you choose, yeah, Ahmed Badruddin? Okay, Ahmed would choose CT, but my passion is MRI, so I choose MRI. So this is not a moving image, but as you can see, the MRI is giving you a very clear delineation and distinction of this mass with a structurally normal heart. This mass contains a clear fluid in most of it, but the bottom part of the flow of the cyst or this structure is of a different attenuation. So probably there is an infection, probably there is a hemorrhage or a hematoma inside, or probably protein content. In MRI, you can see the difference of content of fluid, and you can see that's in the signals very clearly. This is supposed to be a playing image again, but just to delineate, this is a heart. This is the heart, and this is the mass. It's quite a big cyst. And again, the way we do it in MRI is to run through different modalities of assessing what are the possible contents. You can see this is a septa or a septated area here, and again with content downstairs. So my MRI diagnosis was left ventricular was normal function, normal index volumes, right ventricle was normal. There was no enhancement, so it's a clear heart, but there is a large cyst attached to the pericardium, extending from the lateral wall of the left ventricle with the maximum measured diameter, as I could get from the MRI, was 60 millimeters. So my conclusion was a very large pericardial cyst in a patient who was symptomatic. So probably you could go for either way, observe, follow up, or refer for surgery. But as the patient has decided already and he is symptomatic, I decided to refer him for surgery. His wife was an employee in Aramco, so she took him there. And the surgeon did his work. He looked at the MRI. He went with Ahmed. He went back to do the CT, and the CT, the only difference is the measurements of the cyst was bigger, and he advised him to go for surgery. The patient contracted COVID, and the surgery was delayed for 2 months, but afterwards he went for a video-assisted thoracoscopy surgery to remove the cyst. So the findings was a large 10 by 10 centimeters, so it's a quite big one. It's a bit bigger than what I've measured on MRI. So it's large pericardial cyst. It was easily seen, attached to the lower pericardium at the level of the heart apex. That's exactly what it was in both chest X-ray, echo, and cardiac MR. The cyst was only attached to the pericardium via a pedicle with no communication with the pericardial cavity, making the diagnosis of a cyst not a diverticulum. The phrenic nerve was identified and secured throughout the procedure. The cyst was septated, as we could see on the MRI, and contained clear fluid in one content and discolored brown fluid, just as we highlighted in our MRI, and the cyst was removed intact without having to open the chest, following aspiration of some of the content of the fluid to reduce its size. So the histopathology say that the cyst wall is composed of fibrous tissue lined by mesothelium, and the morphological findings are consistent with a pericardial cyst. So pericardial cyst is a diagnosis that everyone in this room practicing clinical medicine is bound to bump into a pericardial cyst. But unfortunately, there is not a unifying structural plan of management in the guidelines as to what to do with them. So I thought of how to discuss briefly about pericardial cyst. To be honest, had it not been for the chest X-ray, I might have dismissed the patient as atypical chest pain and reassured him dismissed. And again, chest X-ray is an important, it has been, will always remain, and the position of the chest X-ray will never be dominated by the rest of the advances of techniques. So incidence is 1 in 100,000. So we each and every one of us is bound to bump into 1 or 2 of pericardial cysts throughout his career. Now, 7% of mediastinal, it constitutes 7% of mediastinal masses, but it's usually silent and detected incidentally in X-ray assessment of another thing. But this patient, he came with chest pain, so it wasn't an incidental finding. It is on the right side in 70%. So again, this is an unusual side. It's in the left side in 22%. There is less than 5% that actually are located in the anterior mediastinum. So you don't see precardial cyst in the famous 4 T's, the differential diagnosis of masses of anterior mediastinum. What are the 4 T's, Mr. Abdel Basit? Teratoma, thymoma, thyroid, and a big aneurysm, thoracic aneurysm. So it doesn't come into the differential, but that is less than 5% of the possibilities. It is reported in autopsy as early as 1837. The first successful surgical removal was in 1931. It arises anatomically due to failure of fusion of mesenchymal lacunae, and some of them are reported to regress intrauterine. So we have a very good structured follow-up of this pathology throughout its career. It has compressive symptoms, and once the patient has symptoms, he dictates the management. It has to be removed. There is no plan for follow-up of a cyst that the patient presents with symptoms. He dictated the management. So if the patient presented with cough, chest pain, you label it the way you like it: irrelevant, atypical, non-specific. Chest pain is chest pain, and it just means that the cyst is compressing nearby tissues. Dyspnea, arrhythmia, recurrent chest infection, all these are reported symptoms of pericardial cyst. Can present with right side heart failure, and this means it's a massive structure. It can present with symptoms of tamponade, and it can get infected. It can get hemorrhage or bleeding, just like this patient. And the most dreadful thing, it can rupture. Differential diagnosis. The most dreadful differential diagnosis is a hydatid. And that's one of the things you want to make sure. You're not going to open up a patient as a possible pericardial cyst and you end up operating on a hydatid, because this is an awful, awful outcome. Localized pericardial effusion, neoplastic like teratomas, bronchial cysts, they all come into a differential diagnosis. And the 2 main tools to diagnose the patient with a pericardial cyst is cardiac CT and cardiac MRI. You choose according to the local expertise of your team in your radiology department. This is a structured kind of possible ways of going through the management of this cyst. If the patient is asymptomatic, you can go either way. Follow the size on a CT or an MRI. If it's getting better, you can go for surgery. But once the patient is symptomatic, you have to operate. The option is yours according to your expertise, whether it's a video-assisted thoracoscopy or otherwise. This is my last slide, and thank you very much for your time.